Hi everybody, this is Teresa, ready with your first attempt at online teaching of medical coding. While I will miss having you in class face to face, we will make this work so you can go out into the world and make a difference. Please keep in touch and let me know how and where you are working. The video will be a lecture using the textbook, Step-by-Step Medical Coding, and the accompanying workbook. You are still responsible to read the chapter, do the exercises 21 through 28, and the quick checks 20-1 through 2013, the chapter review pages 568 and 69. Type up the review as you have all semester and submit your work via email to me, Teresa Lowney at cwi.cc, prior to our class time of 10 o'clock on the due date as listed in our schedule. Okay, here we go. Urinary chapter 20, urinary and male genital systems, pages 497 through 567. All right, so the urinary system, we have them divided according to anatomic divisions. You've heard this all semester. This chapter is kidney, ureters, bladder, and urethra. The procedures on the prostate are either in the urinary or the male genital system, so you need to be careful and see which one. Here we go. So the kidney codes are covered through 50,010 through 5593. The urinary, okay. The endoscopy codes for the procedures can be done either through a previously established stoma or an incision. You need to make sure that your approach is documented. The most cystoscopy procedures have 0 global days. And you remember what that means. If you do anything for the patient in those global days, you're going to code them as separate procedures. The cystoscopy is a visual examination of the urinary bladder by means of the cystoscope. You have to code the incision. You have to be careful. The kidneys are located in the retroperitoneal area, and so your approach can be different. Each incision has a different code for this procedure. The renal exploration, the kidney diagnostic procedure 50,010 has no further procedures performed. If you're only doing diagnostic, remember if it becomes surgical, then you're going to bundle that diagnostic procedure into the surgical. The retroperitoneal area is the diagnostic procedure, and that code is 4910. Renal abscesses. If you have a kidney abscess, you're going to code that because that's exactly what you're going to be you're incising for, and you're going to go in and take care of. The alert here, of course, is if you have radiologic supervision and interpretation, you're going to make sure you're using those 75,000 codes. 989 is the one applicable here. If you have a retroperitoneal abscess, you're going to code that appropriately. Then we have procedures, and in this chapter, it's a hard one for us to begin our online session with because we have so many procedures in this chapter. So one of the first procedures is the nephrostomy, insertion of a catheter into the kidney with one end in the kidney and the other end outside the body. Then you have a nephrotomy, exploration of the inside of the kidney. It doesn't have any definitive procedure, but you need to make sure all those CCI edits are covered, so you don't want to unbundle this. And then we have a nephrolithotomy, the removal of the calculus. What was a calculus? Not math that you hate, but a stone. And then the procedures, some of the procedures going forward, some of the ways that we get rid of those stones, those calculi, we use ESWL. It's the use of the shock waves to fragment the calculus. You have your patient on a waterbed sort of looking thing. It has liquid underneath the patient, and then the shock waves go through the patient, through the kidney calculi, and break those all up. We also have percutaneous lithoscopy, insertion of the probe to pulverize the calculus. At the end of the probe, you have a basket, and then you're going to go in and remove all of those pulverized pieces of the stone. You also have PCNLA. It's percutaneous approach for the same procedure, and it's removing that kidney calculus. Okay, then we get into the excisions codes, 50,200 to 50,290. You have a nephrectomy, partial or total. Remember, total means radical, radical means total. Excision of the kidney. You're going to also remove the fascia, the fatty tissue, and the regional lymph node and the adrenal gland. So you need to make sure that you've covered the entire thing. Okay, then when we're going to talk about renal transplants, kidney transplants, remember we talked in class when we were face to face about all the backbench work that has to be done, and we have to make sure that we're coding for all of this and covering it all. So the backbench work, we have the retrieval of the organ, if it's from a deceased person or a living person, if it's open or done laparoscopically. That approach makes all the difference in the codes. We have to prepare the organ, whether the patient is deceased or living, and then the actual transportation. Now transplantation. It can take without an nephrectomy. I can't even talk, or with one. So you need to read your notes very carefully as to which one. So the code is different for each of those. 60 for without the nephrectomy, and with it is 65. Add the modifier 50 if it's a bilateral procedure, because of course you know that you can have one renal transplant without having both. So you just need to make sure that you're covering those. Then the introduction codes, some of the things that this is going to cover are aspirations, catheters and injections, insertion of guide wires, and tube changes. These are usually reported with a radiology component. Again, you need to read those carefully to make sure that you're covering them. The repairs, one of the most common ones is the repair of the UPJ. It's a pyeloplasty. It's either simple or complicated, or it can include the closure of a fistula. Fistula, of course, you know, is an abnormal opening. And the codes that you would use are listed there. The laparoscopy for ablations of a renal cyst or a lesion. Again, it can be open or percutaneous, and so you need to know the way that you're approaching it and how you're doing it is how you're going to pick the code. Endoscopy codes. This method, of course, is less invasive and divided by those approaches. So it can be performed either through the established connection between the kidney and the body exterior, or it can be a pylectomy or nephrectomy. It can be further divided upon the purpose. Why are you doing this? So is this for a biopsy, or is this for the removal of a foreign body or a calculus? When we get to the ureter codes, this is the next subheading. Again, it's divided according to the type of procedure, excision, incision, etc. So you need to make sure that you're reading all of those notes. Okay, so and you need to know if you're doing it laparoscopically. The laparoscopic codes are going to describe the surgical procedures. The codes may be bilateral or unilateral, so you need to be very careful about watching your 50 modifier. The question number 3 in your exercises is a good explanation of this material. It's a kind of you're on the bottom of page 544, just to review the breakdown of this again. And remember that some payers may require the RT and LT modifiers rather than the 50 modifiers when you're coding bilaterally. You will know that when you go to work, and your office will give you instructions on which to use. Incision or biopsy codes. We have to report all open procedures. Are you exploring or draining it? Are you inserting an indwelling stent? Are you removing the calculus? It's based on the location. Are you on the upper third, the middle third, or the lower third of the kidney? So you need to know exactly where you are. Then we have excision and introduction codes. So an example of an excision is the bladder cuff excision or a total excision, depends on how much you're removing. Introduction, these reports injections, measure pressure studies, mammometric, change of stents or tubes would be codes that would be listed under the introduction codes. Laparoscopic placement of the ureteral stent, and endoscopy codes for procedures through the established stoma. Then we get to the bladder. There's a great illustration in your book of the bladder, and it's listed every single part, because remember, when you're coding these excision codes, you need to know exactly where the site is of this procedure. So there's a different code for a bladder neck, as there certainly is for the dome of the bladder. So remember those 3 things. You need to know the site, the technique, and the reason for the procedure. Okay, so an example we have here is a urethral dilation. Is included with the insertion of the cystoscope. So you're dilating it at the same time you're inserting the scope, and so you would not unbundle and code those separately. Read all the descriptions carefully for the site, technique, and reason for the procedure. incision and excision codes, cystostomy for lesion destruction, insertion of radioactive material, and flagellation, which is the use of the electrical current. These are suprapubic catheter placement codes. The excision codes are going to include cystotomies and cystotomies, cyst O and cyst E. This is when I talk about how important it is to read each letter in a code, see how similar these are, but how those few little letters right here and right there will make all the difference. The codes are divided on the base of the extent of the procedure. The introduction codes here for the bladders are injection procedures, and your radiology is going to be reported separately. The installation of anti-carcinogenic agents via a catheter for bladder cancer, and retention time is included in this code, so you can't code separately for that. Urodynamics, excuse me, procedures relate to the motion, the flow of the urine, the motor, and the sensory functions. Most insurance companies are going to require this urodynamic study before they will do any urinary or approve any bladder surgeries. So these are used to diagnose the urine flow obstructions. They're bundled. They're all usual necessary instruments, equipment, supplies, and technical assistance. You can't code those separately. Always code urodynamic codes in addition to all other cysto codes if both are performed, and generally they will be. Modifier 51 is used for reported multiple procedures in this case. Repair and laparoscopy codes. So we have a cystoplasty, cystourethroplasty, all of these wonderful things for urinary incontinence, and then the laparoscopic codes are used for stress incontinence procedures. So all of our codes here, there's lots and lots of combination codes, so you need to read all of those notes. And all of the notes in your CPT book before the 52,000 codes are indicate that there's all kinds of different calibrations, dilations, the scopes that are used, whether it's cysto or urethral, and urethral catheterization. And you need to be sure that you're reading those very carefully. 52,000 code is assigned for IVP if necessary, if appropriate. So you need to make sure. The 05 code is assigned for retrograde pyelogram. And when coding all of these with dilation, you need to ask the following questions. Most importantly, is the patient a male or a female? Is this an initial or subsequent procedure? Was it a general or spinal anesthesia used? Additional time and effort for the second procedure if there was one performed. You're going to use that modifier 22, remember, for additional time and effort. And you need to make sure that you're noting that because you don't want that second procedure to not get paid. There's transurethral surgery through the urethra or the bladder. So now we have on page 550 and 560 and 561, we have all kinds of alphabet soup listed there. We're going to have all kinds of procedures coming forward. Turbot is one of them. It's the excision or fulguration of a bladder tumor. And then if it goes from the urethra to the bladder, it's one code. If it goes from the ureter to the pelvis, it's another. These include the insertion and the removal of temporary stents, so you can't code those separately. We get into the male genital system, the anatomic subsection. The illustration is in your book. It shows everything from the penis, the testes, the epididymis, the tunica vaginalis, the scrotum, the vas deferens, spermatic code, and the seminal vesices, and the prostate. And of course the prostate is the one we've talked about before, that is the most popular surgeries that we seem to have to code. Okay, under the penis, we've kind of talked about that when we talked about integumentary system codes. All of those incision codes are different in this section than they were then. And of course it talks about the deeper structures that the incisions. And that was would be why we would be coding that. Remember, when we have Cordy, we have the ventricle curve downward, and then the opposite, we have congenital abnormalities that we also code and we correct. So if there is an opening that is abnormally placed, we're going to repair that. Repair codes report repair services for both of those. On the testes, you're going to have incisions, biopsies. You're going to have whether they're incisional or percutaneous. Again, your approach you need to code. We need to make sure if we're talking about a simple or radical procedure, unilateral, bilateral, and with or without testicular prosthesis insertion. We need to know our approach. And then we have explorations. We have undescended testes. This happens sometimes. It can be congenital. It didn't descend into the scrotal sac. It could be unilateral or bilateral, and it's often associated with a hernia, and that's how they find the hernia. So you're going to go in and repair those. We're going to move and fix those, and we're going to use an abdominal approach or a laparoscopic approach. So the code selection, of course, is based on that approach. You want to check those edits for your bundled procedures, and your office will have a cheat sheet that will tell you that. Okay, and now we have the narrow coiled tube at the top of the testes. It connects the efferent ducts to the vas deferens, and so sometimes we have problems with that. We're going to go in and do an irrigation and destruction, abscess or hematoma, depending on what it is, or we can do an excision, and there's biopsies, lesion removals, repairs, and we're going to make sure that if we're using that operating microscope, remember that's the only code in that section, 69990. Sometimes this is at a very appropriate place to be using that microscope. Then we have other codes for the serous sheath of the testes, the site of a hydrocele, a fluid collection, treatment options such as aspirating, injecting, excising, and repairing. There can be a bottle type repair that you will use, which includes a drain and a repositioning. The catheter is left in place. Then we have scrotum ones. So this, of course, is the sac that contains the testes. We can have lesions, abscess, hematomas. We're going to repair all of those. We can have a traumatic defect or a congenital abnormality, and it might include grafting. So you need to make sure if you're using skin grafts, they might be simple or they might be complex, and you need to read all of those and report those complex ones separately. Then we have the tube that connects the sperm from the testes into the ejaculatory duct and urethra. And sometimes we have to do incisions. We're going to collect the sperm sample or identify an obstruction that way. Excision would be a vasectomy. I think you've probably heard of those before. It's for sterilization. It's described as either unilateral or bilateral. Do not use the modifier 50. When you read that code, it includes either, and so you need to make sure that you're not doing that. Introduction, we could be using a dye for the radiographic procedure. The repair is to remove the instruction. And we will always have semen sampling included before and after. Again, we would be using the operating microscope, 699990. Hydrocele 55500 with a modifier 50 if it's bilateral. Sometimes there's trapped blood causing the vessels to swell, and so we'll have to go in and repair those. And again, it depends on your approach. You're going through the scrotal, the abdomen, laparoscopically. Are you excising those? And are you repairing the hernia at the same time? It's going to bundle those two together. So you need to pay attention to that. So watch for the separate procedure designation. It's only billed if the service is performed or if the procedure totally is unrelated to another procedure performed during the same operative session. Then we have the seminal vesicles. So there's a pair of bands from the posterior to the bladder. It provides the majority of the semen fluid. The incision is there. It can be simple or complicated. If you're doing an excision, it's removal of a tumor or calculus or another obstruction. And in this case, it doesn't matter what approach you're using, you're going to use the same code, 55650, and add the 50 modifier if it's bilateral. Then for the prostate, if we have BPH, which is very common in elderly men, benign prostatic hyperplasia, it's an enlargement of the prostate. And we have treatment options here. So the urethral stent will keep the urethra open at the level of the prostate. And there can be permanent ones or temporary ones. So you need to make sure that you're differentiating between those to code. TMUT, microwave heat used for this. TUNA, T-U-N-A, radio frequency. Each code description lists the approach and our bundled procedures if appropriate. So again, you need to pay very close attention to each word there. If you're doing a prostate biopsy, you're probably going to do a needle or a punch biopsy, but sometimes they actually do a needle with a transperineal stereotactic approach or an incision. So when a fine needle biopsy and aspiration is performed, The very first codes that we learned about, the very first chapter, were 10,021 and 10,022 for fine needle biopsy and aspiration. So don't forget about those codes. If that's the way we're getting this sample, then that's what we need to code. Prostateotomy is simple or complicated, and it can have a drain abscess. It can either be through the perineum or through the rectum. And if it's complicated, it will be documented as complexity, such as excessive bleeding. You're going to make sure if you've got excessive bleeding in your problem that you're coding that. Okay, so BPH or neoplasm surgical options, again, it's our alphabetic soup. You can go through the urethra. It just depends on which way you're going and what you're doing. If you're relieving the pressure but not removing tissue, you need to read all of that. This is a really complicated chapter. So we also can use laser vaporization, the TUVP or TVP contact. The electrical current vaporizes the tissue by means of a ball that's rolled over that tissue. You can have it with or without resections, and it will depend upon what's going on with your patient and your provider. Brachytherapy, there's different methods of this. This is the brachytherapy for prostate cancer. You're implanting these seeds you can see on the illustration. It's a high dose and a temporary method, or a low dose that is permanently implanted. It depends on the cancer and the cancer treatment program that your provider is providing. The placement of those seeds is one procedure. It can be transperineal or through the open exposure. Again, you're going to report those radio elements, not with a J code because it's not medication, but with a 77778 or 77799. Again, depending on whether or not they're permanent, low dose, or high dose temporary. Okay, that's all of the lecture for this wonderful chapter. I hope you could follow along and I didn't lose you. And now we're on to the next thing, which is to make sure you do those exercises and do your chapter review. Thank you.